we are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Mood Swings to Mindfulness, Mental Health in Menopause, organized by Chennai Menopause Society. So it's my privilege to introduce the Secretary of Chennai Menopause Society, Dr. Deepa Tangamani ma'am. Ma'am is the consultant at Apollo First Med Hospitals, Chennai, and also Secretary of ATNRCOG from 24 to 26. I welcome you, ma'am, and I hand over the session to you.
Thank you, Sagiti. Thanks for the warm welcome. A warm welcome to one and all of everyone who joined here, all the faculty as well as delegates. And it's my pleasure to introduce the convener of this is the first webinar of this tenure from 2025 to 2027. And I thank President Premlata Madam as well as the whole faculty who has joined today. And my pleasure to introduce Geeta Lakshmi Madam, who is the convener for the day. Madam is a professor of obstetric gynecology from C. Balaji Medical College, and she is a former secretary of OPSI. Madam has many memberships like Chennai Menopause Society, SOPSI, and ISOPAP. She is very much interested into the research and teaching, and her publication is Gestational Glucose Tolerance Research and presented at World Health Journal of Advanced Healthcare and Research. Madam's areas of interest is high-risk pregnancy, adolescent health program, and national master trainer for the HPV vaccinations. Over to you, Madam.
Thank you, Deepa, for the kind words, and very good evening to everybody. It gives me an immense pleasure, and it's really a pride and honor to be a convener of the first webinar of the Chennai Menopause Society of 2025 to 2027. And the topic which is chosen today is a very important topic, that is mental health and menopause, and of which the title is Mood Swings to Mindfulness. So mood swings doesn't occur in adolescence alone. It occurs in menopause also, and it can bring a lot of sudden changes. But mindfulness, it brings us pause, breathe, and handle things, in a very calm manner whenever there are ups and downs in life and all moments of life. So with this, I'm really very grateful to be a convener of this first program. And I thank the President, Dr. Premlata Madam, and the Secretary, Dr. Deepa Tangamani, for giving me the opportunity. And as I said when I started my video, we have two doyens here, Dr. Madhini Madam as the chief guest and Dr. Cynthia Alexander as a guest of honor. And both of them are lucky charms of the OBG field, and they are here to start with the program. And here we go with the program. And I would like to invite our beloved President, Dr. Premlata Madam, to give the welcome address. And Dr. Premlata Madam needs no introduction. She is the President of the Chennai Menopause Society 2025. She is the past President of the OPSI 2022. Consultant and HOD of Dr. Mehta's Multi-Speciality Hospital, formerly Professor of OG, and she's an alumni of Madurai Medical College. And Madam has presented various presented papers in various national and international.
Thank you, Pa.
Over to Madam for the welcome address.
Dear CMCNs, good evening to one and all. It gives me great pleasure today as the first webinar on our tenure 2025 to 2027 to have this webinar, and I welcome one and all. It really helps me great pleasure welcoming my beloved Professor Dr. Madhuri Madam as the chief guest. Madam has readily consented to be the chief guest. Madam, as Dr. Geeta Lakshmi told, yourself and Dr. Cynthia Madam are our mentors, and immediately you accepted it. It is like emotionally we are attached to Oxy also. When I started my first webinar, you were the chief guest, Madam. Thank you, Madam, for accepting to be the chief guest, and I welcome you to the thing, Madam. I welcome Cynthia Madam, ever inspiring and always smiling. And Madam, your presence here means a lot to us, Madam. We are very happy to have this webinar on mental health and menopause. As Geeta Lakshmi told, mental health encompasses our emotional well-being. It actually has psychological and mental well-being is needed for good physical well-being. And today we've chosen the topics in such a manner that it will be of helpful to all the practicing gynecologists, I think. So before standing, I welcome all the faculty members who are here to give the talk on mental health, and all the delegates who have logged in to today for coming here. And I welcome one and all, so that the webinar will be a great success. And I hand over the things to Dr. Deepa Thangamani to introduce the speaker, and go for the Tamil Thai Valthu and very different.
Deepa, shall we go on with the Tamil Thai Valthu and the midlife prayer? Because any program which starts, it is always with the blessings of the Almighty. So we shall go on with the Tamil Thai Valthu and the lighting of Kuttu Vadakku and midlife prayer by the Secretary, Dr. Deepa Thangamani.
Thank you. We'll move on to the Chennai Menopause Society prayer. We pray to God to give us a grace to accept the midlife physical changes and gently renew our strength and guide our heart, our mind and body to navigate the way, and our trust in you to lead us safely through. We pray for midlife and mature women who cherish the fond moments of their life, and also for those sitting in a doctor's office or who are in the bed asking for a healing touch. On this day, may all the midlife and menopausal women have the gift of joy, hope, good health. Thank you, God, for the promise of hope you hold out to all midlife menopause women and inspire us to give this gift of hope to others.
Thank you, Deepa. Now we shall move on to the address of the chief guest. So I welcome Professor Dr. Madhini Madam. And Madhini Madam is a retired professor and HOD of OBGYN Madras Medical College, former director, Institute of Obstetrics and Gynecology, Egmore, past president Oxy, life member of IMA, Oxy, IMS and ISOPAC. And she is received the Foxy Achiever Award, Kaushalya Acharya Award, IMA Lifetime Achievement Award, UGPG for the past.
We'll stop in that, Geeta.
Yes, madam. So,
Time is going on.
madam is a very good teacher and a good academician, and she is interested in high-risk pregnancy, medical education and training. Over to Dr. Madhini, madam, for the chief guest address.
Thank you, Dr. Geeta Lakshmi, for your kind words.
Thank you, ma'am.
Good evening to Dr. Cynthia, Dr. Premalta, and the convener, Geeta Lakshmi, office bearers, faculty and delegates. It's indeed a great pleasure to be the chief guest of the inaugural webinar of the Chennai Menopause Society 2025-27. I thank Dr. Premalta, the president, Dr. Deepa Thangamani, the secretary, and all the office bearers for giving me this opportunity. The Chennai Menopause Society is doing an immense service to all the delegates, public, and the students. Founded by the charismatic Dr. Jayashree Kejaraj, and the strong foundation laid by Dr. Hipsiba Kribamani and the team during their tenure, and then building rapidly under Dr. Shanti Gunasingh and the team. And the CM is growing fast. Under the erstwhile and enthusiastic and sincere present president, Dr. Premalata, and their enterprising team, Dr. Mala Raj, the vice president, Dr. Deepa, the secretary, Jairani, the treasurer, and Nandita, the joint secretary, and all senior executive members, I think it will reach further heights. I wish to make one suggestion that if we can find a way to counsel the youngsters, especially teenagers, the importance of proper diet and exercise so that they can build their bone and muscles at that age, so that in their peri and postmenopause years, it will bear the fruit. That's what we are talking in GDM, that the option should not suffer. So we should start at that age so that in later years, that's what the Kaya Kalpam says. You have got to do it in the period of Brahmacharyam, then only you can get it at the later period. Then recently, the last weekend, I had been to a gathering of even more than 500, between 40 and 70 years. I was invited for that. So when I talked to them about Kegel's exercise, they were really interested in it. So if we can find a way by our NRHN to teach Asha, the ANMs, and spread the news to the rural population so that they can be benefited. I wish all the best for this seminar on mood and mindfulness, and best of luck, and my best wishes for the CMS team 2027 for an interesting and educative sessions for the 2 years to come. Thank you.
Thank you, madam. Thank you, madam, for the very nice words. Your blessings should always be with us, madam. Thank you so much. And now I welcome Dr. Cynthia Alexander, and she is the guest of honor. We always like to have you with us, madam. That is the thing as an obstetrician. And she needs no introduction. She is a former director of IOG, superintendent of Government Hospital of Women and Children, Chennai, and the former professor and HOD of OBGYN Madras Medical College. She's been, yes, madam. And she has received the Lifetime Achievement Award, which is a prestigious award from the DIPSI at Lucknow. Over to you, madam.
So thank you, Geeta. As I greet all the viewers of this webinar, I thank Premalata, Deepa, Mala, and Geeta also, and Deepa also, and all the office bearers of the CMS for this invite as guest of honor. Mood swings and mindfulness. As doctors, it's a very lovely and encouraging heading given. As always, CMS does wonderfully well. So as doctors, how do we ease her pause? We have to ease her pause. So in this fast world, as 30% of women are in their midlife, and with their multitasking between work at home, professional work, family, society, she also experiences mood swings. So this webinar is going to encourage them to take life in its stride of mindfulness. This reminds me that in a few days, as we are preparing to celebrate the 79th year of independence, I recall the words of Tagore, where the mind is without fear and the head is held high. Into that haven of freedom, let my country awake. Also, let our women awake. So, I thank once again all these things so that this mindfulness reaches all our women. And I wish all the best for the speakers. Thank you, and Jai Hind. Thank you.
Thank you, Madam Madhini Madam and Dr. Cynthia Madam, for your real love, and you have been given us good advice and we follow it, Madam. Thank you, Madam Madhini Madam and Dr. Cynthia Madam.
Thank you.
Thank you, madam. Cynthia, madam, you said the mind should be free of fear. So it reminded me when I saw this Tamil Thai Varthu, that Thiruvalluvar Silai I saw. Without a fear, you went to that bridge and you came back, ma'am. So that that is what reminded me when you said that. Thank you very much for the kind words. And now, with your blessings, we will move on to the first scientific session, of which the master of ceremony for the scientific program will be Dr. Bharani Vijayaraghavan, who is a consultant obstetrician and gynecologist of Motherhood Hospital, Chennai. And she was a senior resident at Sri Ramchandra, and she is a consultant of Motherhood Hospitals currently. And she has also presented various papers in national and international conferences. So over to Bharani, and she will lead on with the scientific session. I hope Bharani is there.
Yes, ma'am. Thank you, ma'am. Good evening to one and all.
Good evening, Bharani.
Good evening, ma'am. Thank you so much for the kind introduction, ma'am. I think we'll start with the academic session. Now, as everybody's been saying, menopause is not just physical transition from mood changes to anxiety to brain fog. The mind also feels the shift just as much as the body. So I think in this webinar, we're trying to recognize some of these symptoms early and find out ways to take care of our mental well-being. So for the academic session, I'd like to invite the chairpersons for this evening. Dr. Jairani Kamaraj ma'am. Ma'am is a senior consultant of reproductive medicine, director Akash Fertility Center. She is the joint secretary TNFOG, past president Oxy 2023, vice president of TAPIZAT, South Zone coordinator Foxy No to Wow Committee, associate secretary World Association for Sexual Health, advisory council member World Association for Sexual Health, member of the board of studies of MGR University, and secretary of Indian Association of Sexology. And she's also won the Best Doctor Award by the MGR Medical University, Rajamani Janaki Raman University First Prize in OBG, and Dr. Vadamalayan Endowment Gold Medal in MBBS. We welcome you, ma'am, for being the chairperson. Alongside her, we have Dr. Mala Raj, ma'am, who is the vice chairperson and founder secretary IAG Tamil Nadu chapter, managing council member of IAG, vice president of Chennai Menopause Society in this term, and joint secretary of Oxy, past joint secretary of Chennai Menopause Society, founder and managing director of Firm Hospitals. She's also the past treasurer at Oxy and past secretary of IMS Chennai chapter. She's a trained aesthetic gynecologist, and she's an accredited menopause practitioner, Best Doctor Award from the MGR Medical University, Best Video Award at IAG 2018. And she's been an operating faculty in various conferences. She's also won the Dr. Siuli Rudra Sinha Award, AICOT 2006, and Satyapal Award for Excellence in Minimal Invasive Surgery in 2022, and has authored many chapters and books too. We welcome you, ma'am. And with them, Dr. Ramani Rao, ma'am, who's member of life member of Foxy, Oxy, CMS, IME, ISOPAP. She's won the Best Doctor Award in 2012 from MGR Medical University. Has been a faculty in various national and international forums. Senior consultant and is running an adolescent clinic, reproductive clinic, and menopause clinic at Ambattur, Chennai. A very good evening and welcome to one and all, ma'am. We'll be moving to our first talk by Dr. Padma Priya, recognizing and managing mental health challenges in menopause. May I request the chairpersons to introduce our first speaker and take over the session.
Thank you, Bharani. Thank you, Bharani, for your nice introduction. Anevarukkum Maalai Vanakkam. My great respects to Chief Guest Madam Madhini Madam, and my respect to Cynthia Madam and our President Dr. Premlata, and my loving Mala and Deepa, and all my EC team of the CMS and all the senior Foxians here. And it's my great pleasure to be a part of this first webinar of our CMS 25-27, headed by our President. And it gives me a great pleasure and honor to welcome and introduce the speaker for this session, Dr. Padma Priya Chandran, who is a senior consultant and psychiatrist at Apollo First Med Hospital, Kilpak, and she has been an experienced psychiatrist over 2 decades on mental health, and she is a Harvard certified borderline personality disorder and depressive disorders specialist, and Stanford certified in opioid de-addiction. And she has been certified in Oxford for eating disorders. And she had been teaching faculty over a decade in reputed Dean University in Chennai. And she has been a guide for psychiatry postgraduates, psychology students, and other allied health science students at their thesis work. And she has been the principal investigator for several ongoing research projects and had authored and published research articles in reputed journals. And she has been actively involved in raising awareness about mental health through newspapers, media, social media, and all through her community awareness programs. And her field of interest being the mood include the consultation licensing psychiatry, women empowerment, and mood disorders. And it is very nice to have you here, Dr. Padma Priya. We welcome you to deliver the important aspects of mental health in the menopause, which is really a thing which we need, because we know pretty well the hormones and the mental health always go together, and the mood changes is all because of these basic things which happen during the perimenopause transition. And I think you are the right person to touch on the mental health. And we welcome you, and over to you, Padma Priya, for your deliberations. Over to you, Padma Priya.
Thank you, madam. Very kind introduction, respected senior faculty members and senior obstetricians. It has been a very big honor and privilege to be a part of this webinar. All thanks to my friend Dr. Deepa for having asked me to just deliver a small talk on the mood symptoms during menopause. So this has largely been an unaddressed problem, especially in our society, when the women reach the menopausal age group, covering both pre-menopause and post-menopause. What we see is the predominance of mood symptoms and the associated physical symptoms, which are largely left unaddressed. So this, I thought this has to be addressed at least in this forum, so that the most of the women who come for the psychomotor symptoms of menopause go very unapologetically, we send them away without addressing these symptoms. So I find that it is imperative to address this now. So I will be discussing both the on and the off-label uses of drugs today. When I use the terms woman and female, I refer to people who have ovaries and are experiencing the cessation of ovarian function, either due to normal aging or medical intervention. Next slide. Next slide, please. Today's learning objectives would be, we will be able to know how reproductive hormones influence anxiety and depression. We should be able to differentiate the perimenopausal mood instability from major depressive disorder and generalized anxiety disorder. We need to list the behavioral and the pharmacological treatment options for mood disorder as frequently as we consider premenstrual syndrome. Next slide. Let us start with this woman. This woman is a 47-year-old mom of two teens who has not been on any hormones, who has skipped her 2 periods in the past year. She feels anxious, more irritable and moody than usual. She has hot flushes day and night. Nighttime awakening, she couldn't go back to sleep. She has difficulty in concentrating at her work. She has had a history of postpartum depression successfully treated with SSRIs and therapy, but no further episodes since then. So, what is this likely to be? As we can see, the natural history of hot flushes, you can see that the transition stage, the premenopausal stage, the percentage of people affected with hot flushes is around 45% in people less than 45. In women between 45 and 47, it is as high as 55. And when you look at the age group between 47 and 49, the prevalence of hot flushes is as high as 80%. So among all the age groups, the maximum percentage of hot flashes would be between 47 and 49, and that is the age group when the patients report to us in the OPD with distressing symptoms. So what is it? How are we going to differentiate? Next slide. When you look at major depression, the core features of depression include a sadness or an empty mood, feeling guilty, worthless or helpless, difficulty in concentrating, remembering or making decisions, a change in the eating habits, either a poor appetite or an overeating associated with weight loss around 5% of the body weight, either it is a weight gain or a weight loss, feeling hopeless, poor energy, feeling tired and slowed down, problems with sleep, trouble getting to sleep, staying asleep or sleeping too much, getting very easily angered or irritable, wanting always to be alone or spending too much time alone, a lack of interest in pleasurable activities, namely in hobbies and activities, including sex. So how are we differentiating from perimenopause? The first symptom would be the irregular periods, which is seen in almost 100% of the patients. Hot flushes, as I have told in the previous slide, with 80% of the patients going through this. Patients presenting with urinary and vaginal symptoms, sleep disturbance, sexual disturbance, weight changes, energy changes, and brain fog. This is how we differentiate between patients who are presenting with core major depression during the perimenopausal age group and patients who are presenting with the classical menopausal symptoms. Next slide. So what causes perimenopausal mood changes? As you can see, there is a significant overlap between the biological causes, psychological causes, and social causes. This overlap does have an impact on the mood changes in depression. Next slide. So what are the brain neurotransmitters implicated in depression and anxiety? As you can see in the previous slide, norepinephrine is responsible for maintaining the attention, motivation, pleasure, and the reward, whereas dopamine is implicated for alertness and energy. The anxiety symptoms are arising mainly because of a serotonin deficiency, which can in turn cause obsessions and compulsions. So when all these symptoms have a significant overlap, the patients do experience a mixed features of both depression and anxiety. Next. So depression during perimenopause is likely due to fluctuating levels of estrogen and progesterone, which we all know. Estrogen modulates the serotonin and norepinephrine. Possibly that is why most of the women are protected from some form of psychosis during their earlier reproductive period. Next slide. So what does progesterone do? Progesterone has significant anti-anxiety effects because progesterone targets areas of the brain similar to the anti-anxiety pain and sleep medications. Progesterone has a calming and sleep promoting effects, especially in the postmenopausal women. Possibly that is why we can see the pregnancy glow in patients and some improvement in anxiety disorders because of an excess progesterone. You can see this graph, the hormonal changes in perimenopause, wherein the levels of estrogen rise initially, then they reach a peak, and then there is a fluctuation, and finally they hit the baseline. Whereas the progesterone levels do not show such peaks and troughs, which explains the mood symptoms during the perimenopausal age group. So what is perimenopausal mood stability? When there are fluctuating mood symptoms like irritability, low mood, tearfulness, a decreased energy, and poor concentration, we call it as a perimenopausal mood instability. We can see that near 45 to 68% of perimenopausal women get compared to 28 to 31% of premenopausal women. Which means this is not major depression. Next slide. So it could be major depressive disorder. We can see that nearly 1 in 4 women will experience an episode of major depression at some particular point of time during the perimenopause or menopause. Women with no history of depression are still 2 times the risk for new onset depression in perimenopause. So we may be the only one she is seeing. So we have to be able to determine the diagnosis and treat them accordingly. So the diagnosis of major depressive disorder is very imperative. So how are we going to go about diagnosing major depressive disorder? As you can see, we have a patient health questionnaire, a simpler form of making a diagnosis of major depressive disorder. When you can see 5 or more symptoms in the past 2 weeks, especially over a period of several days, we can make a diagnosis of depression. A few symptoms could be a little interest in pleasure or doing things, as I had already mentioned, feeling depressed, a trouble feeling staying asleep or sleeping too much, feeling tired or having very little energy, very poor appetite or overeating, feeling bad about oneself, that the person is a failure or having let themselves or the family down, trouble concentrating on things such as reading the newspaper or watching television, moving or speaking very slowly so that the other people should have noticed it, or the opposite, being so fidgety or restless or been moving around a lot than usual, thoughts that you would be better off dead or of hurting yourself in some way. So what are the points which characterize depression? If some of these symptoms are prevalent over a period of several days, with as little as 5 symptoms, we call it as a mild depression. When 10 to 14 marks are scored, we call it as moderate. 15 to 19 means very severe, and 20 means the patient has a very severe depression. So this is a very easy questionnaire which can be implicated even in the OPD to screen if the patient is having subsyndromal depressive features. So moving on to the panic disorder or the generalized anxiety disorder. New panic disorder and the generalized anxiety disorder are very common during perimenopause, more common in women with physical symptoms of menopause, especially hot flushing. We have another questionnaire for generalized anxiety disorder. So over the last 2 weeks, if the patient has been experiencing some of these symptoms, we can make a diagnosis of a generalized anxiety disorder. I have filed these questionnaires so that these can be implemented in the OPD and it doesn't take much time. If the patient feels very nervous, anxious, or on an edge, she is not able to stop or control worrying too much about different things, she has trouble relaxing, she is so restless that it's hard to sit still, she becomes very easily annoyed or irritable, she feels afraid as if something awful might happen. These symptoms are scored from 0 to 3. As I've already pointed out, symptoms of 5 to 9 indicate very mild anxiety, 10 to 14 indicates a moderate level of anxiety, 15 plus indicates clinically severe anxiety features. So over 8, if the patient scores over 8, it means it is clinically significant and the patient has to be treated. Next slide. So what we all have to be aware is perimenopause is a window of vulnerability for mood changes. Nearly 68% of the women go through these changes. Risk of major depression goes up even in women with no history of mood disorders. Mood disturbance earlier in life is a significant risk factor for major depressive disorder. So what can we do? So this slide, I have taken it up because this is the first ever guidelines for detecting, treating perimenopausal depression. This was published in 2018. This is a consensus recommendations for evaluation and treatment of perimenopausal depression. So what they have recommended is the panel addressed 5 topics. Next slide. They have discussed about the epidemiology of depression in peri and postmenopause. The presentation of depression in this population is no different, but the diagnosis is complicated by the perimenopausal symptoms. The effectiveness of antidepressants was evaluated. They found out that no difference in younger versus older women. Both were found to be effective. Effects of hormone therapy on mood symptoms. It was found that it was effective in perimenopause, not in postmenopause. Effectiveness of other treatment modalities, namely psychotherapy, somatic or physical symptoms, and natural products. It was found that some work and some do not. Moving on to the epidemiology. Now, who is at risk? We can see that nearly 45 to 68% of perimenopausal women report depressive symptoms. It is found to be higher in Hispanic women. Overall, multiple and varying factors, including socioeconomic, personal, psychological, and social characteristics and health status, are associated with an increased risk. There is found to be an elevated risk in women who have undergone hysterectomy with or without bilateral salpingo-oophorectomy. There is an elevated risk in patients with premature ovarian insufficiency. So moving on to the therapeutic approaches, namely the psycho and the pharmacotherapies. So what are the psychological treatments which are available for patients who are presenting with menopausal depression or anxiety? We all know that cognitive behavioral therapy reduces the frequency of hot flushes. So now it has been proved in nearly 7 randomized control trials. It addresses sexual dysfunction, which is prevalent very rampantly during perimenopausal age group. It addresses the depression and the anxiety features. Insomnia is also addressed. This mindfulness-based stress reduction therapy also improves the distress in women experiencing severe hot flushes and night sweats. So cognitive behavioral therapy for insomnia is advocated for women who would like to sleep quicker and would like to stay asleep longer. So what are the checklist of cognitive distortions which are present during the depressed phase, which can be improved with the cognitive behavioral therapy interventions? Patients can present with all or nothing thinking. That patients look at black and white categories. There is an overgeneralization of the perception, that is, the woman views a negative event as a never-ending pattern of defeat. She dwells only on the negatives. She insists that her accomplishments or her positive qualities do not count. She jumps into conclusions. Like, for example, she assumes that people are reacting negatively to her when there is no evidence. She predicts things which will turn out badly. There is a magnification or minimization of her symptoms. She blows things way out of proportion or shrinks their importance. She has an emotional reasoning for everything that is happening in her life. Like, for example, she says that I feel like an idiot, so I really must be one. There are very often should statements are being used. She criticizes yourself, like shoulds, musts, and oughts. She labels herself, stating that I made a mistake, so I'm a jerk or a fool. There is a lot of personalization involved and lot of self-blame involved. All these cognitive distortions are addressed in cognitive behavioral therapy. So some mindfulness interventions like paced breathing, which is very helpful in cognitive distortions, but I don't advocate it for vasomotor symptoms. There are some apps which are available for progressive muscle relaxation. These apps include Headspace, Simply Being, and Breathe to Relax. Mindfulness-based stress reduction course is also available nowadays. So this, I specifically wanted to put this slide because most of the prescriptions carry these medications. These are the things which do not work. Chasteberry, evening primrose oil, ginkgo, magnesium, St. John's wort, all these are known to be not effective in the perimenopausal depressive phase. So I would like to move on to the prescribing pearls of pharmacotherapy. Estrogen is not FDA approved to treat premenopause instability, but it works. That's a good news. It can work as a hormonal therapy or as continuous oral contraceptive pills. Symptoms recur in the pill-free week. We have to treat the menopausal symptoms if co-presenting in women with major depressive disorder. Addressing sleep disturbance is very important. So considering the role of progesterone in sleep promotion, always recommend exercise for your patients, particularly when combined with psycho and pharmacotherapy. Moving on to the medication treatment for depression, I have put a comparison between selective serotonin reuptake inhibitors or selective norepinephrine reuptake inhibitors versus estrogen. So how are we going to advocate this treatment for which particular subsect of individuals? So SSRIs are the first line for moderate to severe depression or anxiety. This should be given if the woman presents with a previous history of depression. It is most effective if we are going to combine it with psychotherapy. Start very slow and go very slow. Warn the patients of side effects of sweating and insomnia. It is very effective in 2 to 6 weeks. Taking up estrogen, start with estrogen if the patient is perimenopausal and symptoms include the premenopausal insomnia or mild depression or anxiety. It can be used in combination with SSRIs for severe depression in the perimenopause or in menopause, but always in the early menopause because it is ineffective in late menopause. It is effective in 2 to 4 weeks. It is usually not prescribed for postmenopausal depression in the absence of other indicators. Moving on to the antidepressants which can be prescribed during menopause. These are the common antidepressants which I prescribed in my clinical practice. As I told you, selective serotonin reuptake inhibitors, namely vortioxetine, citalopram, escitalopram, fluoxamine, paroxetine, fluoxetine, and sertraline are very commonly used, and they are the first line of medications in our clinical practice. Sometimes when the patient presents with the predominant of somatic features like weight loss and poor appetite and fatigue, we think of adding SNRIs, serotonin norepinephrine reuptake inhibitors like duloxetine, venlafaxine, and bupropion and mirtazapine. So these have been proven to show efficacy in peri and postmenopausal. We need to know the adverse effects before we prescribe the medications. Among the SSRIs, you can see that fluoxetine has a high prevalence of insomnia and agitation, so preference to be given during the daytime. Paroxetine has a predominant anticholinergic effect. It can cause a mixture of both drowsiness as well as agitation. So caution should be exercised in giving in a perimenopausal woman. Sertraline is well preserved. It is one of the safest medications which the FDA has approved. Can be, even though it causes a little bit of insomnia or agitation, it can be prescribed along with melatonin. It is safe in the long run. Some atypical agents such as agomelatine can be used, but we do not use it much in our clinical practice. Bupropion has a very good stimulating effect, especially when the patient presents with a lot of fatigue and vasomotor symptoms. As I've already mentioned, the serotonin norepinephrine reuptake inhibitors can also be used when the patients focus more on the physical symptoms than the psychological symptoms. Among these, we prefer venlafaxine over duloxetine or milnacipran. So my personal approach to antidepressants in perimenopause, sertraline and fluoxetine are activating, so it is very good for the draggy and the fatigued person. Please don't use it for the anxious or the sped up person. Paroxetine and venlafaxine are very calming. It is good for the anxious and the sped up person. Please don't use it for the draggy or the fatigued person. Wellbutrin, that is bupropion, is activating, so prescribe bupropion in the morning. Don't give it at night. Patients will not sleep. It has a very good effect on the sexual dysfunction, especially in the perimenopausal age group. So getting back to this women. So what was it? We can see that the woman was in perimenopause. Her patient health questionnaire score was 9 with mild depression, but she was not fitting the criteria for a major depressive disorder. She had no contraindications to estrogen. She opted to start hormones and follow up shortly. So either the transdermal estrogen with oral progesterone or transdermal estrogen with intrauterine device can be done, or continuous oral contraceptive pills can be given. So you can expect the vasomotor symptoms to improve, possibly the mood and the sleep. Consider antidepressants only at the time if no improvement is present in the mood. You can actually flip the order if depression is more severe. Most important point, SSRIs and SNRIs don't work as well for flushing as hormone therapy. So you need to give hormone therapy along with these SSRIs and these have a negative sexual side effects. So that is the positive side as well. So you can prescribe both simultaneously. This is what she has said. Oprah has said, many women I have talked to see menopause as an ending, but she has discovered that this is a moment to reinvent yourself after years of focusing on the needs of anyone else. It is your opportunity to get clear about what matters to you and then to pursue that all with all of your energy, time, and talent. This I found it very good for a menopausal woman to take it up. So I would like to sum up everything. Perimenopause is a window of vulnerability for mood disorders. There are many effective treatments for depression and anxiety related symptoms of perimenopause. Validate your patient's experience. Pick either a hormonal approach or a mood approach, depending on what is more bothersome, and re-evaluate frequently. Partner with a mental health colleague for non-response to treatment or complex mental health history. So these are my references, and thank you for your patience.
Mala?
Yeah. So, thank you so much. Thank you so much, Dr. Padmapriya. A very, very elusive and detailed presentation on the hormones and the mental health. So it was, I think it was an excellent talk and with lots of take-home messages also. So we move on to the next. Can we move to the next speaker, Dr. Bharani? Yeah. So we move on.
So one thing I just want to add up, Padmapriya. It was very good and nice and
Yes,
elaborated
ma'am.
presentations you have made. Very practically you tipped things about many drugs, especially when you are talking about the drugs, we should be very much personalized and individualized. And I really appreciate all your facts, whatever you have put forth for this perimenopausal women with the mental stress. All the treatment, what you have suggested is very apt and correct. And I really appreciate your presentation. Thank you.
Thank you, ma'am. Thank you, ma'am. Thank you, ma'am.
Thank you, ma'am. We'll move to the next presentation by Dr. Nikat about hormones and mood. I request Mala ma'am to introduce our speaker.
Yeah. So, yet another very interesting and important topic here, the hormones and the mood. The hormones, as we all know, is now taking the downstep. So, the estrogen and the progesterone, sometimes even the cortisol, all that play havoc to the women at this point of time. So, that is the reason why the women is constantly blamed for being very, very moody. So, a very cheerful women suddenly they find the change at home, and then she is constantly being blamed, and everything is only attributed to menopause. So anything in the family they say she's going through menopause, that's why she's behaving like this. So it creating quite a lot of havoc in the family and disruptions in the entire atmosphere. So to know more about this particular aspect of hormones and women, we would like to have Dr. Nikat Nasreen, who is a consultant and laparoscopic surgeon from Mehta Hospitals with almost 15 years of experience. And she is also affiliated to Oxy, MNAMS, IAG, MRSI, RCOG, and IMS, and has various papers presented in various conferences, and also has conducted many workshops and monthly CMEs for the postgraduates. So we would like to hear more on this hormone and the mood from Dr. Nikat. Over to you, Dr. Nikat.
Thank you for your kind introduction, madam. Sharing this. Opportunity. So my topic is on hormones and mood. Madam has already covered few slides. I'll be skipping those and we'll just start now. So agenda, what all I'm going to cover is what is menopausal transition, role of hormones, neuropeptides, neurosteroids, neurotransmitters, prevention and role of HRT, and the summary. Yeah. So menopausal transition is an important period in a woman's life during which she is at risk of mood disorders. Common symptoms are hot flushes, sleep and mood changes, fatigue, weight gain, urogenital disturbances. Clinicians often neglect mood swings and disrupted sleep. They are significant, they are very important, and they can impair the cognitive function and mental health. It is the main estrogen and progesterone fluctuations during the menopausal transitional period causing these mood swings. And after menopause, there will be a low level of estradiol, and they have a profound effect on the CNS, causing an imbalance between the excitatory and inhibitory inputs. Changes in neuroendocrine and neurotransmitter system also affects the physical well-being. Yeah. So the hysteria was the first mental disorder attributable to women since second millennium BC. The first description referring to the ancient Egyptian 19 not BC Kahun papyrus and identifies the cause of hysterical disorder in spontaneous uterus movement. Even Hippocrates is the first to use the term hysteria. Indeed, he also believes that the cause is because of the movement of the uterus. What they did those days is they believed that wandering uterus was the reason for all this hysterical behavior. So, whenever they felt the uterus was moving upwards, they used to keep some fragrant thing down near the vagina and some acrid substance near the patient's nose or the mouth. Or when they felt that the uterus was moving down or wandering down, they used to keep some acrid substance down near the vagina or keep some good fragrant substance near the patient's nose or the mouth so that they felt that uterus will be kept in place. Only in 1816, Charles Perry Lewis included hysteria or nervous affection of the uterus as a typical symptom of menopause. Only in 1816, they attributed it to menopause. But now, we are not supposed to use this word. The concept of hysterical neurosis is deleted with the 1980 Data and Statistics of Mental Disorder, edition 3. Yeah. Those days they felt the uterus was moving here and there, causing mental disorder. So, mood disorder during menopausal transition. So, not only the hormonal changes and the endocrine changes that is causing this problem, but there are various other social factors affecting the women. So it can be because of the interpersonal relationship, socio-economic factor, change in sex life and partner relationship, and body image. Many women at this age, they tend to become more obese, and difficulty in weight loss can create anxiety and stressful life event. Like in family, they can have emptiness syndrome, that is the children can go abroad for studying or can get married and they can be living alone in their house, can increase their stress levels. And aging, skin changes and the body contour changes related to aging can affect them very much. And the personal, culture and education level and previous psychiatric disorder, this is a very important predisposing factor. Whenever women comes with a mood disorder, we need to ask them whether she had similar kind of problem during her reproductive age group or during PMS. Yeah. So let us see what is menopausal transition, because especially in the transition period, she's going to face the maximum disturbance. So this is the Straw-Pleston classification. In this, -2 and -1 corresponds to the menopausal transition. Okay, let us see role of hormones. Madam was already saying there will be estrogen fluctuations during the menopausal transitional period, and later on after menopause it will decline. Then, but progesterone slowly it declines. There will be erratic change in estrogen during the transitional period. Why this occurs is progressive loss of follicles, so there is reduced ovarian hormone secretion. and inhibin B declines, and progressive increase in FSH, and ovulatory cycles become less frequent, and GnRH pulse becomes more frequent. So the transitional is characterized by erratic hormone concentration. As I already told, it might last for around 5 years. Estrogen receptors are densely distributed in the prefrontal cortex and hippocampus region, implicated in emotional processing and memory. Its decline may destabilize these circuits. Okay, so not only hormones, there is a role for neuropeptides also. So this now a lot of researchers, they are speaking more on this kispeptide. The stimulatory neuropeptide are neurokinin B and kispeptin. The inhibitory neuropeptide is dynorphin. So kispeptin, neurokinin, and dynorphin, that's KNDY secreting neurons, is located in the arcuate nucleus and is regulated by estrogen and progesterone level. They control the body temperature and play a vital role in thermoregulation. And also, it's the reason for vasomotor symptoms and hot flashes. What they have, there's a new drug into the market, which is fezolinetant, a NK3R antagonist, that is neurokinin antagonist, showing promising result. It's in a phase 3 study, but it is available. And severity, they found out that it reduces the severity of hot flashes. This drug was recently also applied by the Food and Drug Administration, FDA, as a non-hormonal treatment for VMS. And other drugs like NK1R and NK3R antagonist, elenzenate, combines the effect of VMS and anti-emetic and anxiolytic effect. This is in phase 3. Okay, what are the role of neurosteroids? Neurosteroids, already have discussed about estrogen. Now moving to allopregnanolone. So it is a metabolized form of progesterone. So the GABA system has an essential role in the inhibition of the HPV axis. Its activation has both anti-anxiety and antidepressant effect. So this allo, what it does is, it's a potentiating neurosteroid, GABA potentiating neurosteroid. It can increase GABA response. Allo has a general anxiolytic and calming effect. The role of neurotransmitters. I think this madam had already discussed regarding these 3 neurotransmitters. Serotonin is important in limbic system, modulates the autonomic function, sleep, sexual behavior, mood, and cognitive function. Dopamine is known as reward neurotransmitter. It regulates pleasure, motivation, addiction, learning, and decision making. Noradrenergic, we all know, is for the development of anxiety and depressive disorder. Estradiol strongly affects all these pathways. And dysregulation of the serotonergic and noradrenergic system is associated with the onset of vasomotor symptoms. Yeah, so this is a summary of what all I spoke till now: hormones and the peptides and the transmitters. Okay, so zoomed out image. So just a small revision. So because of less inhibin, there is a reduced estrogen and progesterone levels and fluctuating sex hormones, sex steroid levels, until progressive withdrawal can affect the CNS, along with socio-economic and other social factors. So here is the allopregnanolone. Allo in postmenopause, it goes down. It's commonly associated with mood disorder affecting the GABA pathway. Then serotonin, because of estrogen withdrawal, it can affect the memory, anxiety, and noradrenaline and dopamine pathway. And even this takes place with the help of estrogen. And kispeptide, as I told, it is very if it gets dysregulated, there will be problem with thermoregulation and cause vasomotor symptoms. So vasomotor symptoms. Now the topic is mood, but why are we speaking about vasomotor symptom? Is because 80% of women will be affected by vasomotor symptoms, the commonest symptom. The women might have hot flashes and night sweats. It's a cardinal symptom. This can in turn affect the mood, and it's a bidirectional. VMS can affect the mood, or mood can affect the PM, increased episodes of VMS. So it is bidirectional, and quality of life is affected. That's why we need to address VMS first. And sleep disorder. Sleep disruption affect up to 60% of menopausal women. A pooled analysis of longitudinal data from over 20,000 women found sleep disturbance largely accounted for the association between vasomotor symptom. It's like a triangle. Vasomotor symptom can affect the sleep, or sleep can cause depressed mood. The triangle, all three are interlinked. Since sleep is crucial for memory consolidation. If someone doesn't sleep properly, they will not have a proper memory consolidation. A decline in sleep quality affects the cognition and reduce alertness, often noticed in perimenopausal period. And what they found out is that telephone delivered sleep intervention like CBT was given in insomnia women of 106 postmenopausal women. They found out that reducing insomnia severity and depressive symptoms by about 30%. Sternfeld found the women engaging in moderate physical activity. This we all tell, same way as we say for all the diseases, no, more than or equal to 150 minutes per week, had a 20% lower odds of depressive symptoms by improving sleep and endorphin release. So, physical activity has to be given more important. Yeah. So, regarding sleep, as I told, it's because of the fluctuating neurosteroids inhibiting the GABA pathway, and the reasons for sleep disorders can be because of reduced inhibin. More FSH can cause waking up and dysregulation of KNDY neurons in hypothalamus, and reduced melatonin secretion and circadian rhythm gets disturbed. We can also consider giving them supplements with them melatonin and alter thermoregulation, psychological stress, and reduce progesterone. It can lower the sleep efficacy, shorter sleep time, higher wakefulness, and obstructive sleep apnea is also related to reduced progesterone. Okay, now coming to the prevention. Okay, so WHO defines health promotion as a process of enabling people to increase the control over it and to improve their health. Let us see how we can improve their health and optimize mental health at menopause. Identifying modifiable factors. First, modifiable factor, if they have any problem with home, they need adequate counseling, need to treat that first. And managing troublesome vasomotor symptom and sleep disturbance. First, before treating the mood disturbance, very important to treat vasomotor symptom and sleep disturbance. Healthy lifestyle, reduction of alcohol, smoking, cessation, exercise, and sleep hygiene is recommended by all the societies, especially by Royal Australian New Zealand College of Psychiatrists. Women with previous major depressive disorders can have recurrence at this period because they are more vulnerable at this period. So we need to address them. Evidence-based approach like HRT, non-hormonal medication, non-pharmacological like lifestyle intervention, CBT, and mindfulness-based stress reduction all has to be advised. What is the role of HRT? HRT aims to target VMS, vasomotor symptoms, cognition and mood changes, and genitourinary disturbance, and also in preserve bone mineral density. We need to give a tailored treatment, not same treatment for all women, depending on their age, risk, and body weight, and the history of cancer. All that has to be taken. Overall, the evidence does not support hormone replacement therapy to prevent depressive symptom or major depressive disorder. Someone who already has a depressive disorder has to be given antidepressant, has to meet a psychiatrist. We cannot be only giving a hormone replacement therapy for them. Hormone replacement therapy is like prevention, has to be started in just after the menopause. And estrogen is used as a monotherapy or with progesterone, preferably micronized with women with uterus. Route determined according to the risk of VTE. We all know that transdermal is better. Okay, when to start? So coming to the timing hypothesis, it's more advantageous if it started below the age of 60 and within 10 years of and with less than 10 years spent in menopause. I would say that immediately after her final menstrual period, it's better to start, not later, not at the age of 65 or 70. Recent randomized double-blind placebo-controlled Chronos early estrogen prevention study go along with the favorable outcome with HRT when applied soon after FMP. So you cannot just start hormone replacement or any other treatment SSRI and ask it to come after 1 year. What we have to do is in 3 months we need to review the patient, and after that annual checkup is required unless there are clinical indication for an earlier review. So, what are the clinical challenges faced in our country in managing psychological symptoms? Many healthcare providers are not trained to fully address the mental and sexual health of menopause. Women frequently report feeling dismissed or being given temporary solution rather than real support. So there should be an access to multidisciplinary team, including a psychiatric care, counseling, hormone therapy, relationship counseling. Is all essential for a comprehensive care has to be given. And social initiatives, unlike the Western words, I think we need to destigmatize menopause in our country. Such as introducing menopause cafes, sisterhood network, and peer support groups. Yesterday, while just preparing for this topic, I could see there are social media. There are so many groups, even in India, supporting the women on menopause. But it will be a good idea to start menopause cafes. What is menopause cafes? Like first in Scotland, lady had started a menopausal cafe. Like weekly, they'll be giving advertisement that who all wants to speak on menopause, they can come at this so and so time to so cafe, wearing a pink or a violet dress, and so that they can openly speak about menopause. I think we could initiate such things in our country to destigmatize and encourage women to speak out on this topic. Gynecologists, we are the first point of contact and gatekeepers to mental health care. So what we can do is validated tools like, as Madam had told, MHQ-9 for depression and generalized anxiety disorder 7 scale can be integrated in the routine practice for women, especially reporting with VMS or sleep issues. We can give it to them, and who all requires psychiatric opinion can be immediately sent for an opinion. We need to foster gynecologist psychiatric partnership to tailor the treatment, blending hormonal, pharmacological, psychological approach based on her symptom profile and risk factor. Treatment must be multidisciplinary. HRT is not the treatment for, not a blanket treatment for all the mood disorder. So we need to get an opinion. In difficult cases, when patients who already have some malignancy or something, it's better to also involve endocrinologists. SSRI, SNRI is like venlafaxine offer dual benefit for VMS and mood, though their use requires psychiatric oversight in complex cases. Non-pharmacological treatment like CBT, exercise should be emphasize. So now coming to the final part of the discussion, coming to the summary, we'll just see those blue is all the prevention, like potentially modifying protective factors. We need to address them. Treat the vasomotor symptom, treat sleep disturbance. Positive attitude towards menopause and aging has to be encouraged. Psychological support, healthy lifestyle, and psychological resources like patient information leaflets could be shared. And what are the risk factors? Early menopause, surgical menopause is a risk factor, and long menopausal transition, sleep disturbance, frequent vasomotor symptom, sex steroid variability, mood sensitivity, attitude, negative attitude for menopause. And in social stressful lifestyle, lifetime, any previous history of depression, childhood experience, adverse experience, unemployment, lack of social support, lifestyle like sedentary, high BMI, smoking, personality trait can increase the problem. While the physical symptoms are frequently addressed in clinical practice, the psychological dimension of this transition remain underexplored. Perimenopause is a critical window where hormonal, pharmacological, psychological intervention can mitigate the depression and anxiety. Proactive screening and multidisciplinary care ensure tailored support in high-risk women. Evidence calls for integrating the strategy like routine practice, like transforming menopause from a period of vulnerability into women empowerment and well-being. Optimal choice of treatment is a complex decision. It requires an individualized approach depending on the degree of it influencing the quality of life. And references, these are my references, and thank you.
Yeah, thank you so much, Dr. Nikat. It is very, very nice and excellent presentation. Various aspects of menopause and mood you have highlighted so beautifully. There is a very nice terminology which I came across called the neurotism, whereas
Yes.
yeah, that is negativity behavior. So women who have this negativity attitude, they are found to be suffering more from this kind of problem more than the others. So this is ideally because I believe there is the fluctuation in the hormones is more significant in these women than women who have a very positive attitude in life. So as you have rightly mentioned, so identification of these women is what is very vital in management, rather than, when they come back, when they come during the menopausal period with all this depressive episode, then obviously we don't have much to offer it to them. But when we know that these are the women, high risk women who can develop problem in the menopausal age group, it is a family who has to, bring the patient up to us. Otherwise, they are not going to open up. So it is a very, I think it is a very most important aspect is we have to counsel the entire family. So that is the reason I think the Club 35, all that is very, very important activity of the IMS, because we are targeting the younger colleagues and then advising them about all these risk factors, so that if they have anyone in the family, they will be able to, bring them for advice, and we are able to take care of them. Otherwise, as you have mentioned, all the entire elaborate things you have covered beautifully. Of course, the hormonal therapy do not have much role in these things. Most of the things are we have to depend on our psychological colleagues only. Antidepressive medications and all those things, to some extent, the lifestyle are also going to help. So thank you so much for the excellent presentation. And I would like to thank Chennai Menopause Society, Madam Premlata, Madam the President, and the Secretary, Dr. Deepa, for giving us this honor of chairing this session. And I'll move on to the next chairperson to take forward the next talk and the proceeding.
Uh, our next talk is about mindfulness by Ms. Neetu. The mind has a habit of running marathons, but sometimes it just needs to sit down for a cup of tea. And mindfulness is that simple, powerful practice that helps us take a moment of pause and breath. May I request our chairperson, Ramani Rao ma'am, to introduce our speaker, Ms. Neetu Kumari.
Yeah, thank you. Thank you for inviting me, ma'am, and this whole CMS group president and secretary Deepa, for me to introduce this speaker. So now we are coming to the real action. So far, we have been bombarded with all the scientific information. So now it is time for action. So it is my pleasure to introduce my friend Neetu Kumari Verma. She's a yoga therapist, dietitian, skincare expert, cupping therapy expert, and a health coach. Her objective here is to deliver holistic wellness solutions. She has done her MSc in yoga therapy from Bengaluru University. And before I list out all those long skills and specializations that she's having so far, I would like to quote one incident. This is the first time when I happened to meet her. That was in Goa. I had gone for a vacation, and this girl, young lady, she comes in, and just it was like a fresh breath coming in, an energetic, bubbly lady. And as soon as we got to talk to her and got introduced, she motivated us in such a way that, the next morning we were on the terrace with our yoga mats, and she took a whole session on yoga. And I remember, Neetu, you taught us about that three-step dance. It was superb, and it activated everything right from head to foot. All our body was activated and energetic, but not to your level. But I think I should take some steps to come to that at least. So coming to you, I'll take over. Neetu, please tell us about mindfulness, which is now the need of the hour. Neetu?
Yes. Thank you. Thank you, Devi. Thank you, Dr. Ravni. Thank you. Thank you, everyone. Actually, yeah, it's a great honor to speak with you today about this important and deeply personalized topic, because we all are women. One day we all have to go through these things, right? So today's topic is mental health during the menopause. So, and our theme is mood swing to mindfulness. Okay. So I'm going to talk about some yogic practices actually, which can be helpful. Actually, definitely it is helpful. And it will help us to embrace the menopause phase with the grace. Okay. So we all have discussed, right, that what is menopause and what happens during this thing. So what is the mood swing when you don't have the control on your mind? Okay. Because of hormones, maybe multiple reasons, because that time hormones are so high and we don't have the mastery. So in yogic things, we will talk about the mastery. So how do we can mastery on our mind? So it is called MMM, mastery on our monkey mind. So because we know our mind, no, sometimes it is here, all of a sudden you can find it somewhere else. You are talking to someone, and the other second, you can thinking something else. And I'm sorry because sometimes I'm talking very straightforward. Mindfulness, I would request to everyone, whoever is there in the meeting, please switch on the camera. This is also a part of the mindfulness. Okay. Because if you are here in the meeting, whatever you do, be aware of that. And believe me, whatever I'm going to tell you guys, it will be so helpful, not only for you, but if you know this, you can guide your patients also. So I'm so sorry, I'm very much young than you. Still, I'm talking like this because I have less time and I have to complete many things. I hope. Thank you. So, see, what is mindfulness? Everything what you do, just be present on that. Simple things, day-to-day life. If we are eating, at the same time we are scrolling the mobile phones, right? So this is not mindfulness. If we are reading a book, the same time we can't listen to the music. If we are doing this, we are multitasking. Sometimes it's good, but mindfulness is the boon we can have. So whatever you do, if you are studying, study nicely. If you are eating, focus on your food. Just enjoy your sense. Now these days, now everybody experience. Kids are small, they are not eating properly, so the parents handed them the mobile phone and they are eating. They don't know what is the taste, what is the color, what is the texture of the food, but they are eating. So these type of food is not going inside and working properly. When you feel it, when each and every cells of your body feel it, enjoy it, then it absorb it, and then your body get nourishment. So this is a small thing, but this is the unit unit of the body, the smallest unit. Okay. So as I'm a yoga person, so I'll tell you about yoga. So yoga has 8 limbs. Okay. So it is called yama, niyama. Maybe it is too much for you, but I will explain everything. Yama, niyama, asana, pranayama, dharana, dhyana, samadhi. So we will go from start. Yamas means the rules which we should follow with the society, with the people, to the other person. And niyamas, this is the discipline we have to follow for ourselves. Like how to talk to other person, how to treat elders, the moral values. These comes under yamas, right? Niyamas. So how we have to keep ourselves clean, happy, like this. So and asanas, when it comes to yoga, na, everybody think, okay, this asana, that asana, but this is a part of yoga. Asana is a body, physic postures only. Okay. And then pranayama. Pranayama means this is the mindful, the breathing practice with awareness. We are taking breath, right? But believe me, 98% people are not taking breath properly. So when we inhale, we have to feel, yes, we are inhaling. I will give you some practices also after some time. Then, okay, fine. Dharana means when you do anything, just focus on that. If it is a study time, you have to focus on your study. If this is your clinic time, you are completely focused on your patients. That time you are not entertain other things, right? And if you have to put effort for all those things, it is called dharana. And when it happens automatically by your consistent practice, it becomes dhyana. Dhyana means meditation. People say na, ki, okay, we should do meditation. So keep your eyes closed and just focus on your mind. Focus on one thing. Suppose that uh, focus on one dot. It is shiny, golden shiny dot. So how will you do? If you close your eyes for a second, okay, you see, and the other second, your mind will be somewhere else. Then again, you have to bring back your mind at the same place. Then you are putting effort, right? But when you do the focusing repeatedly, consistently, one time will come when your effort will be less. Automatic, you will go through the meditation. Okay. And when this stage comes now, this is the stage where, the feeling of oneness completely merger. Okay. Um, the moksha word, right? This thing. So now I'm going to discuss what practices are there which can be helpful for the menopause thing. So we will start from the scratch. Okay. So first thing, sensory presence. The thing I have told you now, you have to be the sense completely. When you are inhaling a flower, you are the nose only. Forget about the whole body. Your nose, the fragrance, and the fragrance when you inhale, signal will go to your brain and it will make you happy. At the same time, you will enjoy the fullest. We use the perfume, right? Why? It gives happiness. Ultimate goal, happiness. Same thing, eating the food with awareness. So, sensory thing, you have to feel. Whatever you do, just feel it. When, suppose that you came late and your kid hugs you, at the same time, you can't be busy in your mobile, right? At the same time, you will hug back your kid and you can feel the touch, the happiness. So, this is mindfulness. Sometimes we do with awareness and sometimes it happens. So, awareness is important. Okay. The asanas we are saying, right? So, asanas gives the balance in our body. Multiple benefits are there, but because we are talking about the menopause and the mental health, so asanas give you the stability, improves your willpower, upgrade your thought process. So when you practice yoga things, you will feel in the morning if you do yoga practice, automatically your happy hormones will secrete. You will be energetic throughout the day. So asanas are important. Then pranayama. Pranayama is the um, breathing practices, but with the awareness. When you do it, you have to feel your body, you have to feel your breath, you have to feel the effect. When you are doing pranayama, be there, be your sense, what you are doing. Okay.
Neetu, can
And
you demonstrate? Can you demonstrate this mindful
yeah,
breathing? Yeah.
now I'm giving the theory part. After this, I will do and I will make you do also. You can experience. Okay. So after that, after pranayama, dhyana portion is there. So dhyana means, we do puja, we do worship. So we close our eyes, we recall the God. Just we feel the emotions actually that time. So this is meditation. And the last but not the least is yogic deep relaxation. So this is a relaxation technique. So you have heard the yoga nidra, have you? Yes. So what? It is the body scanning. It's your body and you can feel it. If you run, you can feel your heartbeat, right? So this is the highest thing. But when you inhale, could you feel something here at your nostril? When you inhale, your chest get expand. Could you feel it? Yeah, everybody can feel it. But the thing is, you need the awareness. Whatever we are doing, our mind is not here. If you bring your mind here at present, you can feel it, anything. Okay. So how it works in menopause. Okay. So mindfulness creates space between your emotions and responses. Instead of reacting on the things, uh, you can observe the thing. Excuse me, what happened? Hello?
Hello, Neetu.
Yes. Oh, sorry. Am I visible? Am I audible?
You are
Hello?
audible, but your video is frozen. You are audible, Neetu.
Yes, yes, yes. Maybe some mistake by my side, I think. Now am I visible?
Yeah, yeah.
Yeah. Okay. So what I was saying is, कि, when something happens, don't react on that thing. Okay. We can observe the thing. We can respond with grace. Okay. By accepting emotional changes, we cultivate self-compassion. One of the best gift during the menopause. Okay. Mindful practices reduce stress, improve sleep, and foster resilience. It helps in multiple ways. Okay. So what I feel ki if you do, then you can experience, you can feel. So are you ready to do with me some practices here?
Yes.
So again, I'll request you all to please switch on the camera so that I can see you all, guys. So nothing more to do. Just sit in a relaxed way in your chair, wherever you are sitting. Just sit properly. But one thing, keep your spine straight. Spine is straight. Just place your palm down, eyes closed, lose your body. No control, okay? Eyes closed and be happy. Smile on your face. Smile on your face with closed eyes. Switch on the camera, but eyes should be closed. Smile on your face and lose your body. Now you will inhale deeply. Inhale. Exhale completely. Inhale deeply. Exhale completely. Just feel it with closed eyes. Believe me, you will feel so much better in just 5 to 10 minutes. You will experience it. With closed eyes, when you inhale, feel the chillness in your nostrils. Could you feel? No need to reply, just feel it. While exhaling, you can feel the warm sensation. Feel your nostril. Inhale the coolness. While exhaling, you can feel the releasing of the heat. Just relax your body. Maintain your lovely smile, all the ladies here. Now you can feel your breath completely, how it is going in and going out. Now you can feel your lungs. Just feel it. Your lungs are expanding and then slowly relax. With closed eyes only, just feel. With closed eyes, breath in, breath out. Even you are able to feel your diaphragm movement. Just feel it. When diaphragm is going down, pushing the abdomen, it's coming out. Abdomen is coming out. And while exhaling, again diaphragm is coming up and your abdomen is sinking in. With closed eyes, deep breath in and out. Now from nostril to your lungs, till your abdomen, you can feel your breath. In a single breath, this much movement is happening inside. Breathing with full awareness. Inhale, abdomen is going out. Exhale, it's coming in. Maintain your smile, be happy. Now we will go for the deep relaxation. So just follow whatever I'm saying, okay? Now bring your awareness to your toes, just with closed eyes. Feel it, that you can feel your toes. You can look at your toes. Do some movement in your toes and feel it. You can feel the movement. Now slowly bring your awareness to your ankle joint. Move it slightly. Slow movement. Stretch your toes and pull it. Do your ankle movement, very slow movement. You can feel the movement. Yes. You are doing the movement in your ankle, but you can feel the effect in your shin bone, in your calf muscles. Just feel your body. Feel the relaxation in your shin bone and your calf. And slowly bring your awareness to your knee joint. Feel the relaxation there. Now slowly come up and try to feel your thigh muscles, your upper thigh, your back thigh, side thigh, the inner thigh. With closed eyes only. Just feel it. Now slowly bring your awareness to your hip region. Squeeze your buttocks and then relax. Squeeze it and then release it. Inhale deeply. Exhale. Inhale deeply. Exhale. Keep your eyes closed. Feel your body. Feel the relaxation. Enjoy the moment. Be happy. Now, bring your awareness to your spine, your lower back, your middle back, and upper back. If someone touches your back, you can feel it. Then feel it that you are touching your own back, and you can sense your cells on your back. You can feel your spine. Come up, feel your scapula. Similarly, bring your awareness in your front. Feel your lower back, lower abdomen. middle portion, and then upper abdomen also. Come up, feel your chest. Inhale and exhale. While inhaling and exhaling, actually you can feel your intercostal muscles also. Just feel it. Enjoy your breathing. Now focus, bring your awareness to your both hands, the fingers. Now you can feel your fingers, feel the relaxation there, your palm, opposite side of your palm, feel it. Wrist joints, with closed eyes, you have to feel your body, your forearm, your elbows, your upper arm, shoulder joint, the collarbone. Just feel it and relax. Deep relaxation. Inhale deeply and exhale. Now bring your awareness to your neck. Feel your neck. While inhaling and exhaling, you can feel the windpipe here. You can feel the movement. The air is passing, so you can feel it also. Now slowly bring your awareness up on your face. Feel your chin, your jaw, your lips, your cheeks, your ears. Feel your nose, again the nostril. Again feel the sensation, hot and cool. Slowly come up. Feel your eyes. Eyes should be closed. You can feel your eyebrow, your eyelashes, eyelids, your eyeballs. Now come to your forehead and feel the relaxation there. Now feel the relaxation on the side of your heads, right and left, and then back of your head. Feel the relaxation. Now slowly bring your awareness to the crown, to the top of your head. And if you want, you can place your palm on the top like this, very slightly, very slightly. Eyes closed, deep breath in and out. Now we will chant 3 sounds. First, akara, then ukara, then makara, then makara all together. How? I will demonstrate first, and then for next 3 rounds, we all will do together. Okay? First, akara. Ukara. Makara. then a, u, ma, kara in a single breath. Now we all will do together. Start with akara. Relax. Now join your palm in Namaskar Mudra. Now you can rub your palms, generate some heat, make it cup shaped, and cover your eyes. All the lovely ladies, with some blinks, open your eyes and look at your palm. Namaskar.
Thank you. Thank you, Neetu. Thank you. That was really lovely. And I think this is not enough. This session is not enough for you. We can take a whole 1 hour like this. But it was really relaxing and very, you put it across that how mindfulness can really change the game, especially for menopausal women. And it is the need of the hour. Thank you, Neetu. Thank you very much for coming and accepting this invitation and being a part of our webinar today. Thank you.
Thank you. Thank you, Niti. It
Thank
was
you.
very nice and relaxing.
Thank you everyone for listening to me.
Yeah.
May you carry this all yogic tools into your everyday life, nurturing yourself, mental health throughout the life.
Thank you.
Thank you so much, everybody. Thank you.
Thank you, ma'am. Thank you so much to the chairpersons too for chairing this session so well. Just a word for all the delegates and faculty. There is going to be a quiz on mental health and menopause, whatever we've deliberated through this. So a Google form link will be shared in the chat box by the end of this webinar. This module was created by Geeta Madam and Deepa Tangamani ma'am. So I request all the members of the Menopause Society to take up this quiz. So this is going to be valid for the next 24 hours. And we've got 3 prizes for people for the fastest fingers first. So whoever gets the most number of correct answers first will be eligible for 3 prizes. And the winners will be announced in the Menopause Society WhatsApp group. So hurry up and follow this Google link and fill up the form. With that, we've come to the end of the academic
Will
session.
it be there
May I
after the
request
Zoom
Nandita
also
Thakur,
meet?
ma'am?
The Google form, how can we
Ma'am,
download,
the
ma?
link is there in the chat box now, ma'am. So you'll be able.
Okay. Now itself we have to download, no?
No, madam, the link
Yes,
will be
ma'am.
even, we will be sharing in this menopausal group also. So they
Okay,
have
okay.
24 hours to open the link and
Okay.
finish the
So you can
quiz.
share it in the group so that it will be easy
Yeah,
for us.
yes, ma'am.
Yes, ma'am. Yes, ma'am. And you've got 24 hours to give in your answers, and the winners will be announced in the Menopause Society WhatsApp group as well.
They were doing
may
it
I now
every
request-
week. We are doing it once a month.
Yes, yes, ma'am.
Okay.
Okay. So to wrap up this session and to give the vote of thanks, may I invite Nandita. Nandita Thakur ma'am is the Medical Director, Nandita's Fertility and Research Center, Academic Head and Coordinator, Senior Consultant, Mehta Hospitals, and Joint Secretary for Chennai Menopause Society 2025. Over to you, ma'am, for the vote of thanks.
Okay. Thank you, Varni. It gives me
a great pleasure to deliver the vote of thanks for this meeting. Mental health and menopause, mood swings to mindfulness, a very well curated program involving Dr. Nikat Stock, Padma Priya, and Neetu Kumari. It was wonderful. We also thank our convener, Dr. Geeta Lakshmi, our chief guest, Dr. Madhuni, for her wonderful words, and the guest of honor, Dr. Cynthia, with all her, usual zest. Thank you for being a part of this wonderful program. I also acknowledge the Shield Connect Sahiti for helping us with this webinar. Thank you once again.
Thank you, ma'am. So we'll leave for today, ma'am. Thank you, everyone. Thanks, Barney. Thank you, Prince, madam.
Thank you, ma'am.
Everybody, pa.
Yeah.
I think I'll tell everybody the second Wednesday of every month we'll be having the same time.
Yes, ma'am.
Thanks for the
Yeah.
cooperation.
Thank you. Thank you so much, madam. Thank you,
Thank
Deepa.
you.
Bye.
Thanks, ma'am.
Thank you,
Bye,
Bharat.
ma'am. Bye.